Imagine a constant battle waging within your own body, a relentless assault on your digestive system that never truly ceases. This isn't a sci-fi scenario, it's the daily reality for millions living with inflammatory bowel disease, or IBD. We're talking about Crohn's disease and ulcerative colitis, conditions that transform the very organs responsible for nourishing you into a landscape of chronic inflammation, pain, and unpredictable symptoms. These aren't just bad stomachs, they are complex, systemic autoimmune disorders that can profoundly impact every aspect of life, from diet and daily activities to mental well-being. Today, we're going to pull back the curtain on IBD, dissecting its complexities, demystifying its mechanisms, and shining a light on what it truly means to live with this silent, yet incredibly impactful, disease. Prepare to dive deep into the world beneath the surface, where the gut holds secrets to a profound health challenge. First, let's establish what IBD actually is. It's a collective term for chronic inflammatory conditions of the gastrointestinal tract. Unlike irritable bowel syndrome, IBS, which primarily affects gut function without causing structural damage, IBD involves actual inflammation and tissue damage within the intestinal walls. This distinction is crucial. IBD is an autoimmune disease, meaning the body's own immune system mistakenly attacks healthy tissue, leading to persistent and often severe inflammation. This misguided attack results in a range of debilitating symptoms and can, over time, lead to significant complications if not properly managed. Understanding this fundamental difference is the first step towards comprehending the gravity and nature of Crohn's and colitis. Globally, IBD affects a substantial and growing number of people. While traditionally more prevalent in Western countries, its incidence is rising worldwide, particularly in newly industrialized nations. Current estimates suggest that over 3 million Americans and over 2 million Europeans live with IBD, and these numbers continue to climb. This escalating prevalence underscores the importance of awareness, research, and improved access to care. The societal and economic burden of IBD is immense, encompassing healthcare costs, lost productivity, and a significant impact on patients' quality of life. The global spread of IBD also points towards potential environmental factors interacting with genetic predispositions. Although Crohn's disease and ulcerative colitis both fall under the IBD umbrella, they have distinct characteristics. The primary difference lies in the location and pattern of inflammation. Ulcerative colitis typically affects only the large intestine, colon and rectum, and causes continuous inflammation of the innermost lining of the bowel. Crohn's disease, on the other hand, can affect any part of the digestive tract, from the mouth to the anus, and often presents with skip lesions, areas of inflammation interspersed with healthy tissue. Furthermore, Crohn's inflammation can penetrate deeper into the bowel wall, affecting all layers, which leads to different complications. These distinctions are critical for accurate diagnosis and tailored treatment strategies. Let's first focus on Crohn's disease. It's characterized by chronic inflammation that can occur anywhere along the gastrointestinal tract, though it most commonly affects the end of the small intestine, ileum, and the beginning of the large intestine, colon. The inflammation in Crohn's is typically transmural, meaning it extends through all layers of the bowel wall, from the innermost lining to the outer muscle layers. This deep inflammation can lead to a range of severe complications beyond superficial irritation, including strictures, fistulas, and abscesses. The skip lesion pattern, where inflamed sections are separated by healthy tissue, is another hallmark. The unpredictable nature of its location and depth makes Crohn's particularly challenging to manage. Now, turning our attention to ulcerative colitis. This condition is specifically limited to the large intestine, encompassing the colon and rectum. Unlike Crohn's, the inflammation in ulcerative colitis is continuous, starting from the rectum and extending upwards. It primarily affects the innermost layer of the bowel wall, the mucosa. While not as deep as Crohn's inflammation, the persistent superficial inflammation can still lead to significant ulceration, bleeding, and severe symptoms. The confined location and continuous nature of ulcerative colitis mean that surgical removal of the colon, colectomy, can be curative in some cases, a stark contrast to Crohn's where surgery often manages symptoms but doesn't eliminate the disease due to its widespread potential. The exact cause of IBD remains elusive, but scientists believe it's a complex interplay of genetic predisposition, environmental factors, an altered gut microbiome, and an aberrant immune response. It's not caused by one single factor but rather a perfect storm of elements. For instance, while genetics play a significant role, you're more likely to develop IBD if a close family member has it. It's not a purely hereditary disease, meaning not everyone with genetic markers will develop it. Research continues to identify more specific genes linked to IBD, many of which are involved in immune system regulation and intestinal barrier function. This multifactorial etiology makes finding a single cure incredibly challenging. Genetics are a strong contributing factor. Over 200 genes have been identified that are associated with an increased risk of developing IBD. Many of these genes are involved in immune system regulation, intestinal barrier function, and the body's response to bacteria. For example, the NOD2 gene is one of the most well-studied genetic risk factors for Crohn's disease, playing a role in the immune system's recognition of bacterial components. However, having these genetic markers doesn't guarantee you'll develop IBD, they simply increase your susceptibility. This highlights that genes create a predisposition, but other triggers are usually needed to set the disease in motion. The hereditary component is evident in families with multiple affected members. Environmental factors also play a significant, though less understood, role. Lifestyle elements like diet, smoking, and antibiotic use have been implicated. For example, smoking is a well-established risk factor for Crohn's disease, often leading to more severe disease and a higher need for surgery, while it paradoxically may offer some protective effect against ulcerative colitis in some cases, though smoking is never recommended due to overall health risks. The Western diet, characterized by high intake of processed foods and low fiber, is also being investigated for its potential role in altering the gut microbiome and promoting inflammation. These external factors can act as triggers in genetically predisposed individuals. The gut microbiome, the vast community of microorganisms residing in our intestines, is increasingly recognized as a key player. In individuals with IBD, there's often an imbalance in the gut flora, known as dysbiosis. This can involve a reduction in beneficial bacteria and an increase in harmful ones. This altered microbial landscape can disrupt the intestinal barrier, making it more permeable, and lead to an exaggerated immune response against normally harmless gut bacteria. Scientists are actively researching how to manipulate the microbiome, potentially through probiotics, prebiotics, or fecal microbiota transplantation, to restore balance and reduce inflammation in IBD patients. It's a complex ecosystem whose disruption can have profound effects. Ultimately, IBD is characterized by an aberrant immune response. For reasons not fully understood, the immune system, which is designed to protect the body from foreign invaders, mistakenly identifies harmless bacteria, food components, or even cells lining the digestive tract as threats. This triggers a sustained inflammatory response, leading to the tissue damage seen in IBD. This friendly fire causes constant irritation, ulceration, and thickening of the bowel wall. Understanding the specific pathways involved in this immune dysregulation is crucial for developing targeted therapies that can precisely modulate the immune system without suppressing it entirely, offering more effective and safer treatment options. This self-attack is the core pathology. The symptoms of IBD can vary widely depending on the location and severity of the inflammation, but common manifestations include persistent diarrhea, abdominal pain and cramping, rectal bleeding, weight loss, and fatigue. Diarrhea can be severe and frequent, sometimes bloody, indicative of inflammation and ulceration. Abdominal pain ranges from mild discomfort to debilitating cramps, often worse after eating. Unexplained weight loss occurs due to malabsorption and increased metabolic demands from inflammation. Fatigue is a pervasive symptom, often disproportionate to activity levels, and can be severely debilitating, impacting daily functioning and quality of life. These symptoms wax and wane, often in cycles of flare-ups and remission. Beyond the digestive tract, IBD can manifest with extraintestinal symptoms, affecting other parts of the body. These can include joint pain and arthritis, skin lesions, like erythema nodosum or pyoderma gangrenosum, eye inflammation, uveitis or episcleritis, and liver or bile duct problems, primary sclerosing cholangitis, PSC. These systemic manifestations highlight that IBD is not just a gut disease but a systemic inflammatory condition. The presence of these symptoms can sometimes even precede the onset of digestive symptoms, making diagnosis more challenging. Managing these extraintestinal manifestations often requires a multidisciplinary approach involving specialists beyond gastroenterologists. The diagnostic process for IBD is often complex and involves a combination of medical history, physical examination, blood tests, stool tests, and endoscopic procedures. Blood tests can reveal markers of inflammation, like CRP and ESR, and anemia, while stool tests check for infection and markers like fecal calprotectin, which indicates intestinal inflammation. Endoscopy, such as colonoscopy with biopsy, is typically the gold standard. During this procedure, a doctor can visualize the bowel lining, assess the extent and pattern of inflammation, and take tissue samples for microscopic analysis, confirming the presence of IBD and differentiating between Crohn's and colitis. Imaging studies like MRI or CT scans may also be used to assess the small intestine or detect complications. Endoscopy, specifically colonoscopy and gastroscopy, plays a pivotal role. During a colonoscopy, a flexible tube with a camera is inserted into the rectum to examine the entire colon and the end of the small intestine, terminal ileum. This allows direct visualization of the mucosal lining, identification of ulcers, inflammation, and strictures, and collection of tissue biopsies. For suspected Crohn's in the upper GI tract, a gastroscopy might be performed. These procedures are crucial not only for initial diagnosis but also for monitoring disease activity, assessing treatment effectiveness, and screening for complications like dysplasia, precancerous changes, in long-standing ulcerative colitis. The visual evidence is often definitive. Imaging techniques provide further insights, especially for Crohn's disease, which can affect areas beyond the reach of standard colonoscopy. Magnetic resonance enterography, MRE, or CT enterography are specialized scans that allow visualization of the entire small intestine, identifying inflammation, strictures, or fistulas that might not be visible during endoscopy. These non-invasive methods are vital for assessing disease extent, particularly in the jejunum and ileum, and for detecting complications like abscesses. Capsule endoscopy, where a patient swallows a tiny camera, can also be used to visualize the small bowel, though it cannot take biopsies or provide therapeutic intervention. Each imaging modality offers unique advantages in mapping the disease. Once diagnosed, the primary goals of IBD treatment are to induce and maintain remission, alleviate symptoms, improve quality of life, and prevent complications. There is no one-size-fits-all approach, and treatment plans are highly individualized, often evolving over time. The journey begins with understanding that IBD is a chronic condition requiring ongoing management, not just acute treatment during flare-ups. This long-term perspective guides therapeutic decisions, aiming for sustained relief and minimizing the disease's impact on daily life. Achieving mucosal healing, where the intestinal lining returns to a healthy state, is now a key therapeutic target, as it's associated with better long-term outcomes and reduced risk of complications. The medical management of IBD involves a stepped approach, starting with less potent medications and escalating as needed. Aminosalicylates, 5-ASAs, like mesalamine are often first-line for mild to moderate ulcerative colitis and sometimes for Crohn's. They work locally in the gut to reduce inflammation. Corticosteroids, such as prednisone, are powerful anti-inflammatory drugs used to induce remission during flare-ups, but their long-term use is limited due to significant side effects. Immunomodulators like azathioprine and methotrexate suppress the immune system more broadly to maintain remission and reduce steroid dependence. These medications form the foundation of IBD therapy, each with its own benefits and risks. Biologic therapies represent a major breakthrough in IBD treatment, particularly for moderate to severe disease that hasn't responded to conventional medications. These are advanced drugs, often administered via infusion or injection, that target specific components of the immune system responsible for inflammation. Examples include anti-TNF agents, like infliximab and adalimumab, anti-integrin agents, like vedolizumab, and anti-interleukin agents, like ustekinumab. Biologics are highly effective in inducing and maintaining remission, promoting mucosal healing, and reducing the need for surgery. However, they can increase the risk of infections and have potential side effects, requiring careful monitoring. These targeted therapies have revolutionized IBD care. Small molecule drugs are another emerging class of therapies, offering oral alternatives to biologics. These include Janus kinase (JAK) inhibitors such as tofacitinib, which block specific signaling pathways within immune cells to reduce inflammation. Unlike biologics, which are large protein molecules, small molecules are chemically synthesized and can be taken orally, offering convenience for some patients. They provide another targeted approach to managing inflammation in IBD, particularly for ulcerative colitis and increasingly for Crohn's. As with all powerful medications, their use requires careful consideration of efficacy, safety profiles, and patient-specific factors, but they expand the therapeutic arsenal available to clinicians and patients. This class represents a significant step in diversifying treatment options. Diet plays a complex and often misunderstood role in IBD. While diet does not cause IBD, certain foods can trigger symptoms in individuals, especially during flare-ups. There is no universal IBD diet, and dietary recommendations are highly individualized. Many patients find relief by avoiding trigger foods, which commonly include high-fiber foods, spicy foods, high-fat foods, and lactose. Some specific diets, like the Crohn's Disease Exclusion Diet, CDD, or Specific Carbohydrate Diet, SCD, are being researched for their potential to induce remission, particularly in children. However, nutritional support, often through oral supplements or even enteral/parenteral feeding, is crucial for preventing malnutrition and aiding healing, especially during active disease. Working with a registered dietitian is key. Surgery becomes an option for IBD patients when medical therapy fails, or when complications such as strictures, fistulas, abscesses, or severe bleeding arise. For ulcerative colitis, a total colectomy, removal of the entire colon, can be curative, often followed by the creation of an ileal pouchanal anastomosis, J-pouch, to restore bowel continuity. In Crohn's disease, surgery is typically conservative, aiming to remove only the diseased segments of the bowel, as the disease can recur in other areas. Surgical interventions in Crohn's are often for managing complications like strictures or fistulas, not for cure. While surgery can offer significant relief and improve quality of life, it's a major decision with its own set of risks and long-term implications. Living with IBD extends far beyond managing physical symptoms, it profoundly impacts mental and emotional well-being. Chronic pain, unpredictable flare-ups, frequent doctor visits, and dietary restrictions can lead to significant stress, anxiety, and depression. Many patients experience feelings of isolation, embarrassment, and fear of public situations due to urgent bowel movements. The invisible nature of IBD means that others often don't understand the severity of the condition, leading to a lack of empathy. Mental health support, including therapy, support groups, and stress reduction techniques, is an integral part of comprehensive IBD care. Addressing mental health is just as crucial as treating physical inflammation. It's a holistic challenge. The impact of IBD on daily life is far-reaching. Patients often face challenges in education, employment, and social interactions. Missing school or work due to flare-ups or appointments can hinder academic and career progression. Social activities, travel, and even eating out become complicated due to dietary restrictions and the constant need for restroom access. Dating and intimate relationships can also be affected, requiring open communication and understanding. Fatigue, a hallmark symptom, can severely limit participation in hobbies and sports. Adapting to these limitations while striving for a normal life requires immense resilience and support from family, friends, and healthcare providers. It's a continuous balancing act. Pregnancy for women with IBD requires careful planning and management. Ideally, conception should occur during a period of remission, as active disease can increase the risk of complications for both mother and baby, including preterm birth and low birth weight. Most IBD medications, including biologics, are considered safe during pregnancy, but this should always be discussed with a gastroenterologist and obstetrician to ensure the safest possible regimen. Regular monitoring and a multidisciplinary approach are essential to ensure a healthy pregnancy and positive outcomes for both mother and child. It's a testament to medical advancements that many women with IBD can now safely carry pregnancies to term. Children and adolescents with IBD face unique challenges. The disease can interfere with growth and development, leading to delayed puberty and stunted growth. Nutritional deficiencies are common due to malabsorption and reduced appetite. The psychological impact on young patients can be profound, affecting body image, self-esteem, and social integration. Managing IBD in children requires a specialized pediatric gastroenterology team, focusing on optimizing nutrition, minimizing side effects of medications, and providing psychological support for both the child and their family. Early diagnosis and aggressive treatment are crucial to prevent long-term complications and ensure healthy development. The burden on young lives is immense. The risk of colorectal cancer is elevated in individuals with long-standing ulcerative colitis and Crohn's colitis. This is due to the chronic inflammation which can lead to cellular changes over time. Regular surveillance colonoscopies with biopsies are crucial for early detection of dysplasia or cancer. The frequency of these screenings depends on the duration and extent of the disease, family history of colorectal cancer, and presence of primary sclerosing cholangitis. Early detection significantly improves prognosis, making adherence to screening guidelines vital for IBD patients. This is one of the more serious long-term complications requiring vigilant monitoring and proactive management. Research into IBD is continuously advancing, bringing new hope to patients. Scientists are exploring novel therapeutic targets, including new biologic and small molecule drugs that act on different inflammatory pathways. Gene therapy and stem cell therapy are also areas of active investigation, holding promise for future treatments. Understanding the gut microbiome more deeply through advanced sequencing techniques is leading to potential microbiome-based therapies. Personalized medicine, tailoring treatments based on an individual's genetic profile and disease characteristics, is a major focus, aiming for more effective and safer outcomes. The pace of discovery is rapid, offering a future with better management and potentially a cure. Precision medicine aims to revolutionize IBD care by moving away from a one-size-fits-all approach. This involves using an individual's genetic makeup, biomarkers, and disease characteristics to predict how they will respond to different treatments. For example, identifying specific genetic markers could help doctors choose the most effective biologic therapy from the outset, avoiding trial and error. This approach also seeks to identify patients at higher risk of complications or those who might benefit from early, aggressive therapy. By tailoring treatments to the individual, precision medicine hopes to optimize outcomes, reduce side effects, and improve the overall patient experience. It's about getting the right drug, at the right dose, to the right patient, at the right time. The role of patient advocacy and support groups cannot be overstated. Organizations like the Crohn's and Colitis Foundation provide vital resources, education, and advocacy for patients and their families. They fund critical research, raise awareness, and offer platforms for patients to connect, share experiences, and find emotional support. These communities reduce feelings of isolation and empower individuals to become active participants in their own care. Sharing personal stories, navigating challenges together, and advocating for better policies and funding make a tangible difference in the lives of those affected by IBD. It's a powerful collective voice for change and understanding. Early diagnosis is paramount for better outcomes in IBD. Recognizing symptoms early and seeking medical attention can prevent the disease from progressing to a more severe state, reduce the risk of complications, and allow for timely initiation of effective treatment. Delaying diagnosis can lead to extensive bowel damage, increased need for surgery, and a poorer quality of life. Awareness campaigns are crucial to educate the public and healthcare professionals about IBD symptoms, encouraging prompt referral to gastroenterologists. The sooner IBD is identified and managed, the better the chances of achieving and maintaining long-term remission and minimizing its impact. Don't dismiss persistent gut issues. Living with IBD requires a proactive approach to self-management. This includes strict adherence to medication regimens, even when feeling well, as this is crucial for maintaining remission. Regular follow-ups with the healthcare team are essential for monitoring disease activity and adjusting treatment. Patients often need to become experts in their own bodies, tracking symptoms, identifying triggers, and communicating effectively with their doctors. Stress management techniques, maintaining a healthy lifestyle, and a supportive network all contribute to better long-term outcomes. Empowering patients with knowledge and tools for self-management is a cornerstone of effective IBD care. It's a partnership between patient and medical team. Education is a powerful tool in combating the challenges of IBD. For patients, understanding their condition empowers them to make informed decisions, advocate for themselves, and manage their disease effectively. For caregivers and family members, education fosters empathy and equips them to provide better support. For the general public, increased awareness reduces stigma and promotes understanding, creating a more inclusive environment. Healthcare providers benefit from continuous education on the latest research and treatment advancements. By spreading knowledge, we can improve diagnostic rates, enhance care, and ultimately improve the lives of those affected by IBD. Knowledge truly is power in this journey. The future of IBD treatment is bright, with ongoing research promising even more effective and personalized therapies. From novel drug targets to advanced diagnostic tools and microbiome modulation, the landscape of IBD care is rapidly evolving. The ultimate goal is not just symptom management but achieving sustained, deep remission and, eventually, a cure. Continued investment in research, collaborative efforts among scientists and clinicians, and strong patient advocacy will be critical in realizing this vision. Every new discovery brings us closer to a world where IBD no longer dictates the lives of millions. The hope for a cure fuels relentless scientific pursuit. To recap, inflammatory bowel disease, encompassing Crohn's disease and ulcerative colitis, is a chronic autoimmune condition causing inflammation and damage to the digestive tract. It's a complex interplay of genetics, environment, and immune dysfunction. While symptoms primarily affect the gut, IBD can manifest systemically. Diagnosis relies on a combination of tests, with endoscopy being crucial. Treatment involves a range of medications, from traditional anti-inflammatories to cutting-edge biologics and small molecules, with surgery as an option for complications. Beyond the physical, IBD significantly impacts mental health and quality of life, necessitating holistic care and strong support systems. The journey is challenging, but hope is growing. If you or someone you know is experiencing persistent digestive symptoms like chronic diarrhea, abdominal pain, or unexplained weight loss, it's crucial to seek medical attention. Don't dismiss these signs as just a sensitive stomach. Early diagnosis and intervention can make a profound difference in managing IBD and preventing severe complications. Talk to your primary care physician, and if necessary, request a referral to a gastroenterologist. Your health is paramount, and advocating for yourself is the first step towards getting the right diagnosis and effective care. Listen to your body and seek professional guidance without delay. Prompt action can significantly alter the disease's trajectory. In conclusion, IBD is a complex, life-altering condition that demands comprehensive understanding and multifaceted management. While challenging, the advancements in diagnosis and treatment offer significant hope for improved quality of life. By fostering greater awareness, supporting research, and promoting empathetic care, we can collectively work towards a future where IBD is not only better managed but perhaps one day, cured. Thank you for joining us on this deep dive into Crohn's disease and ulcerative colitis. Your understanding and empathy contribute to a world where those with IBD feel seen, supported, and empowered. Let's continue to advocate for better health for all.